All right, let's do some practice questions. As before, what I'm basically going to do is just click to the next slide, and then I'll let you guys pause it, take as long as you need to read it through, think it through. Pardon me, then select your best answer, and I'll tell you what it is. So, first question. Pancreas and gallbladder excrete their products into which segment of the duodenum? Go ahead and pause, then answer. All right, answer is B, the second or descending part of the duodenum. Next up. All right, the answer on this one. You can find the portal triad, the hepatic portal vein, the proper hepatic artery, and the bile ducts, common bile duct and common hepatic duct, in the hepatoduodenal ligament. C is the correct answer. Go ahead and pause. Restart when you're ready. All right, the answer is plicae circularis, or A, circular folds. So that's what you find in the small intestine. The haustra are those individual little compartments that are formed by the smooth muscle, the circular and longitudinal muscle in the large intestine. So that's haustra. Microvilli and villi, C and E, are features of the small intestine, but they're not visible. The microvilli are on the surface of the cells. They're super tiny. The villi are not visible, but they give the velvety appearance to the intestinal lining that it has. The rugae are the folds that you would find inside the stomach. So that is all why A is the correct answer. Hey, this question is actually unfair because this is one that I'll be asking you after you've had the innervation talk. So let's just play along. Give it your best shot. All right, now hopefully you guys remember that all the parasympathetics to all these organs are going to be preganglionic until they get to the wall of the organ. So preganglionic parasympathetics make C or D the correct answer. So we can flip a coin, and in this case it's going to be C. It's going to contain postganglionic sympathetics on that celiac plexus. If that seems unfair, it is, and I should have put that on the next talk, but I'm not going to go back and change it around right now. We'll just keep on plowing forward. Right? Right. All right. A little bit of a callback here. Don't freak out. Just take a moment and think it through. Unpause when you're ready. All right, so if we are extending our back, that's locking our vertebral facet joints into a closed position. So A is the correct answer. Flexing our torso forward would open the vertebral facet joints, and side bending one way or the other would open one and close the other. So if I side bent left, I would be closing my left facet joint and opening my right facet joint, and the opposite for D. Okay, now we're back to full-on abdomen stuff. Take a moment, pause, and restart when you're ready. And the correct answer is C. So linea alba, B, is going to be that midline structure where all the tendons insert. C, the correct answer, linea semilunaris, is on the lateral side of the rectus sheath, and that's where those muscles have to transition to an aponeurosis. Vertebral spinous process, that's way far back. That's not going to be correct. And then the inguinal ligament is where the external abdominal oblique's aponeurosis kind of fuses with the ilium and pubic bone. Once again, C is the correct answer here. All right, do your best. Let me know when you're ready. All right, so if we're rotating strongly to the right shoulder moving posteriorly, right shoulder moving posteriorly, left shoulder moving anteriorly, we would be contracting B, the left external abdominal oblique and the right internal abdominal oblique. Let's see, rectus abdominis and transversus abdominis, that would make us do a sit-up, so we'd flex forward if that were the case. A, left external oblique and left internal abdominal oblique, those would be fighting each other. So that really wouldn't result in much, and the same holds true for E, right external and right internal. And then if we had the right external oblique and the left internal oblique contract, we'd do the opposite. We would rotate our trunk strongly to the left, so the right shoulder would move anteriorly. All right, pause. As soon as you're ready, come on back. All right, so coronary artery bypass has happened. We've used the right internal thoracic artery, so one of its immediate branches is likely going to be deprived of blood unless we've got a little anastomosis elsewhere. So the internal thoracic artery gives off the musculophrenic and superior epigastric artery. So E is the correct answer here. All right, so now we're doing an incision through the abdomen. So where are we at? We're passing through the linea semilunaris, 4 inches superior to the umbilicus. So superior to the umbilicus, that's going to be above the arcuate line. So if we go through the anterior aspect of the rectus sheath, what do we pass through in order? All right, well, skin has to be first, but that's true of all of them. So then we have to figure out if it's campers or scarpas that's next. And it's campers first, then scarpas. So D and E are out. So we're left with A, B, and C. Now after that, we're going into the rectus sheath, and it's going to be the rectus sheath superior to the arcuate line. So external oblique aponeurosis. Okay, those all have that as the next option. Now we get to the point where we're distinguishing. It's going to be half of the internal abdominal oblique aponeurosis. That's what makes up the anterior part of the rectus sheath above the arcuate line. So A is the correct answer here. Now, if we were doing this below the arcuate line, we would actually have all of the external, all of the internal, and all of the transversus abdominis aponeurosis going anterior to the rectus abdominis. But that doesn't make B or C correct because we wouldn't even have the transversus fascia and peritoneum in front. So once again, A is the correct answer. Next up, all right, and this is describing a psoas abscess. So we've got a psoas abscess. It got from the vertebra to the psoas muscle, and it went from the thoracic cavity into the psoas. So it had to pass through the diaphragm to do that. And the psoas is covered by C, the medial arcuate ligament. So lateral arcuate ligament, that's quadratus lumborum. B, that's going to be psoas major, so that's the correct, C is the correct answer. And D, median arcuate ligament, that's the part of the diaphragm covering the aorta. Next up. All right, so we've got hemidiaphragm, bulging of the diaphragm up into the thorax. Diaphragm is innervated by C, the phrenic nerve. I will keep asking this until everybody in class gets it right. Phrenic nerve, C3, 4, and 5, innervates the diaphragm. Now the intercostal nerves, they have some sensory input to the diaphragm, but not motor. And sympathetic chain, not going to innervate the skeletal muscle of the diaphragm, nor will the vagus nerve do that. Okay, pause, come back when you're ready. All right, so we have an indirect inguinal hernia. That means we are going to be having the gut going out the deep inguinal ring into the inguinal canal and out the superficial inguinal ring, probably. So that is going to be starting lateral to the inferior epigastric artery, which is the lateral umbilical ligament. The peritoneum that covers the inferior epigastric artery makes the lateral umbilical ligament. And C is the correct answer. By the way, if it was medial to the lateral umbilical ligament, that would make it a direct inguinal hernia. So make sure you've got that relationship down. All right, and what do you think? B, filiform papillae are those spiky ones. The others all have taste buds associated with them. All right, so what's the microstructure of the gut? And this is actually the area that you do use to make anastomosis between loops of gut. E, the submucosa. It's actually the densest connective tissue part and can be used to anchor sutures, and it's going to be between the muscularis mucosa and the muscularis externa. So submucosa, once again, is the correct answer. All right. right, who's got a mesentery? The answer is D, sigmoid colon. Now, if I had transverse colon, ileum, and jejunum in there, those would also be valid answers. But of the things on this list, only D has a mesentery. All right, so let's see what we got. Transverse colon needs to be removed after an ischemic event. Which artery, in terms of our normal anatomy, not all the variations, but the normal anatomy, supplies the transverse colon? That would be C, the middle colic artery. So right colic to the ascending colon, middle colic to the transverse colon, and left colic to the descending colon. All right, next up. Same basic setup, but now, after some of the vasculature has been ligated, what vessel allows blood to be shared between regions of the large intestine? That would be, most correct, C, the marginal artery. So the marginal artery will carry blood from the right colic and left colic to the section of gut that's had its artery ligated. So right colic and left colic, they're involved, but marginal is what actually allows the blood to be shared. So just make sure you're giving every answer the opportunity to be correct before jumping to kind of make it a final answer on the exam. Okay, next up. Okay, so where does blood from the inferior mesenteric vein go? It goes to the splenic vein, D. And then splenic vein will join with the superior mesenteric vein to make the hepatic portal vein. Okay, pause. Come back when you're ready. All right, so as we're marching up the aorta, the inferior mesenteric lymph nodes are going to get lymph from the hindgut. They're going to drain up to the superior mesenteric lymph nodes, which also receive lymph from the midgut. And lymphatic fluid from those superior mesenteric lymph nodes, correct answer, will go to the celiac nodes. A is the correct answer. All right, we asked what had a mesentery before, now we're asking what doesn't. But it's secondarily retroperitoneal, meaning it once did. Transverse colon has a mesentery, no good. Stomach has a mesentery, it's hanging out in the abdominal cavity, so no. Sigmoid colon has a mesentery. Kidney, little tricky here, kidney is retroperitoneal, but it's primarily retroperitoneal. It never developed inside the abdominal cavity. Only A, the ascending colon, had a mesentery that fused at the body wall, making it secondarily retroperitoneal. So A is the correct answer. All right, what do we have? All right, so the iliodiverticulum is what's left of that connection between the midgut and the yolk sac, and that connection is the vitelline duct, D. Just while we're here, respiratory diverticulum, that makes the lungs. Hopefully nobody picked that. The hepatic diverticulum is going to generate the liver, the gallbladder, and the ventral pancreatic bud, and it grows into the septum transversum, but that's all foregut stuff. Vitelline duct is correct. All right, what's next? All right, one of these things is not like the others. One of these things does not belong. One of these things is not part of the portal triad, and the answer is B. The hepatic artery, hepatic portal vein, and bile duct, those travel together from macroscopic to microscopic, whereas the central vein stands on its own, but fuses with other central veins to make the hepatic veins. All right, take a moment, read through this one, come back when you're ready. Okay, so we've got issues involving the gallbladder. How do we know gallbladder? Well, abdominal pain, a lot of stuff can cause that. Right upper quadrant pain after fatty meals, that is screaming gallbladder dysfunction at you. Right upper quadrant, and the gallbladder is trying to constrict and contract to release bile after it receives the signal that there's fat to be mobilized. So we've got that. Jaundice, telling us that we've got some problem involving backup of bile. And diffuse pain across the stomach and back. Pancreatic enzymes are very elevated, so we're looking for a place where the biliary tree and the pancreatic drainage come together. And while cystic duct, common bile duct are all going to be involved with the the bile drainage doesn't account for the pancreas. Main pancreatic duct is the opposite. It accounts for the pancreas, but not the biliary system. And hepatopancreatic ampulla C is the correct answer because that's where the two come together, and a stone there can block both systems. Now, if we had a stone within the lumen of the second portion of the duodenum, we wouldn't care. The stone's been passed, it's moved into the GI tract, and it will be just shed with the feces thereafter. So once again, C is correct. Okay, just know your branching pattern. Come back when you're ready. All right, the gastroduodenal is a branch of the common hepatic. So common hepatic splits into the gastroduodenal and proper hepatic. And then we've got left gastromental coming off the splenic. Splenic is a separate branch of the celiac, and the right gastromental is generally going to come off of the proper hepatic or sometimes off the gastroduodenal. So one more time after all that, gastroduodenal artery is a branch of A, the common hepatic artery. And how do we find the cystic artery? How do we impress our surgical preceptors when we get a little further out into training? We find the triangle of Callot, and the triangle of Callot is bounded by the common hepatic duct, the cystic duct, and the inferior border of the liver. C is the correct answer. All right, you guys are awesome. Keep working hard. We'll get the pelvic videos out to you soon. I miss seeing all your smiling faces, and I hope you're doing well.